I'll be taking you through a tale of shaky eyes and stiff bones. My aim is to report a rare case of foveal hypoplasia with nystagmus in a patient with autosomal dominant osteopetrosis. Osteopetrosis is a hereditary metabolic bone disease with increased density and brittle bones. Severe cases can be presenting with pathological fractures, pancytopenia, cranial neuropathies, and hepatosplenomegaly. Foveal hypoplasia is when the foveal pit does not develop fully. It can be associated with poor vision and nystagmus, and it is seen commonly in conditions of albinism, aniridia, coloboma, optic nerve hypoplasia, and retinopathy of prematurity. Variants in genes associated with osteopetrosis are as follows, and the genes associated with foveal hypoplasia are as follows. Most common visual association of osteopetrosis is that of optic nerve atrophy due to optic canal stenosis following bony sclerosis. My case is that of a 10-year-old female presenting to the OPD with complaints of involuntary shaking of both eyes associated with decreased vision since birth, no history of consanguinity or any other systemic illnesses, antenatal and perinatal history were unremarkable, and age-appropriate developmental milestones were achieved. On examination, she had bilateral horizontal jerky nystagmus, which was left beating in moderate in amplitude and frequency and dampened on right face turn. On Hirschberg, she had right exotropia of 30 degrees, and on cover test, she had right exotropia with left eye fixation preference. On prism bar cover test, she had 30 prism diopters of base in for distance and 20 prism diopters base in for near. Her best corrected visual acuity was 636 N6 in the right eye and 618 N6 in the left eye with refractive correction. Her color vision was 2/21 in both eyes. Her applanation tonometry showed pressures of 16 in right eye, 15 in the left eye. Pupils were round, regular, reacting to light in both eyes, and extraocular movements were full, free, painless. Anterior segment examination was within normal limits, but the posterior segment showed a marked temporal pallor of the disc, absent foveal reflex, and a normal background and vasculature. We did ancillary testing, which was OCT, optical coherence tomography, which confirmed our suspicion of foveal hypoplasia. There was absence of foveal pit seen in both eyes with asymmetrical shallow foveal contour seen, right thicker than the left. The temporal pallor led us to ordering MRI brain and OCT for the patient. On axial T2, we could see thin optic nerves and chiasm, and there was also a finding of diffuse calvarial thickening. This led the radiologist to suspect osteopetrosis or pycnodysostosis, for which she suggested more radiological imaging, and we did X-rays for the patient. The X-ray images showed skull lateral view, showed diffuse sclerosis with skull base thickening. Spine lateral view showed rugger jersey spine with hyperostotic vertebral end plates, and there was bone and bone appearance in the leg bones. Pediatric evaluation, systemic evaluation was within normal limits, and blood tests were also within normal limits. To confirm diagnosis of osteopetrosis, we did genetic evaluation, and a heterozygous missense variation was detected in exon 11 of the CLCN7 gene, which was likely pathogenic for autosomal dominant type 2 osteopetrosis. The variant was C937GA or P-GLU313-LIS, which results in the amino acid substitution of lysine for glutamic acid at codon 313. My diagnosis was that of foveal hypoplasia along with autosomal dominant type 2 osteopetrosis. We managed the patient conservatively by giving her yolk prism trial, and prism glasses were prescribed, and vitamin D supplementation was given by the pediatrician. This case shows a novel genetic presentation involving C937GA variant encoded in the CLCN gene, which is very scarcely reported in the literature. Wang et al. Reported similar variant associated with severe fractures, but in their study only one patient became blind and was diagnosed with optic atrophy. None of the other patients had visual deterioration or loss over time, and visual loss, they suggested, were due to bone remodeling, due to optic canal caliber in childhood. So this case is the first to show an atypical presentation of foveal hypoplasia with clinically and genetically diagnosed autosomal dominant osteopetrosis. Similar nucleotide variants can present with different severity of phenotypes, and further studies can be done to evaluate the role of exome sequencing in clinically suspicious osteopetrosis to better classify variants of this disorder. These are my references. I would like to acknowledge. Thank you. Presenting on role of parenteral smoking in myopia systematic review.
नहीं मैं आपको व्हाट्सएप करूँगा ना, मैं आपको व्हाट्सएप करूँगा जो
As
मुझे
we know
भेजेंगे
that
जैसे पहले
with the
भेजी थी।
current myopia epidemic, it is predicted by 2050 the number of myopes will be half of the world population. Parenteral smoking has been shown to be associated with refractive error, and literature shows a mixed effect on development of myopia. This systematic review evaluates the current evidence on the role of parenteral smoking in childhood myopia. This protocol was registered in Prospero. Search was done across 3 databases, that is Scopus, PubMed and Web of Science. And search strategy was run through the databases using appropriate Boolean operators with following keywords: parenteral smoking, maternal smoking, paternal smoking, myopia children and risk factors. The studies which had children under the age of 18 and association between parenteral smoking and childhood myopia were included in this systematic review. PRISMA 2020 guidelines and risk of bias was assessed using Newcastle-Ottawa scale. This is the PRISMA chart. Initially 91 studies were identified and duplicates were removed, and then we screened the abstract and the title, and 33 studies were removed, and then full text of all the studies was retrieved, and finally 16 studies qualified according to the inclusion and exclusion criteria. The data extraction was done in an Excel format based on the predefined criteria, that is the patient demographic characteristics, exposure criteria, what was the smoking type and frequency, myopia diagnosis, whether the confounding factors were adjusted or not, the study results, and what was the quality of the study and risk of bias. Now coming to the results, the sample size varied from 300 to 12,000 children, and the studies were mainly based in China, Hong Kong, Singapore, UK and United States. 12 studies were cross-sectional studies and 4 were longitudinal cohort studies. The spherical equivalent which was there in these studies as a definition of myopia was less than or equal to -0.5, and 11 studies used cycloplegic refraction as a diagnosis for myopia and 5 used non-cycloplegic refraction. All the 16 studies adjusted for confounders which are commonly present like age, gender, parental education, parental myopia and socioeconomic status. The exposure was collected through self-reported questionnaires in most of the studies, and only 5 studies they used a validated biomarker in terms of measurement of the urinary creatinine levels. The studies varied in measurement of the smoking exposure. Some measured the maternal smoking during pregnancy, some measured the current smoking, and some household smoking frequency. Finally, the 10 studies were identified as showing protective association in terms of lower myopia prevalence and higher hypermetropia prevalence. 6 studies showed that second-hand smoke exposure can lead to increase in axial length and more myopia. And it was shown that the children who were exposed to high daily cigarette crowns demonstrated a high degree of severe myopia, odds ratio varying between 1.8 to 2.9 for every additional 10 cigarettes smoked daily. The risk of bias was assessed by Newcastle-Ottawa scale, and it was shown that the quality of studies, 9 studies was high, 5 was moderate and 2 were low. The limitation of the evidence in terms of the studies which were included were that there was a self-reported of the parental smoking habits which can introduce a recall bias. The incorporation of biomarkers in terms of urinary creatinine was not universally done, and cross-sectional model of the 12 studies which were included, it limits the establishment of causality, and we need longitudinal cohort design for causal inference. The current review, we excluded non-English studies, so language bias was introduced, and unpublished literature was not included. So publication bias was introduced, and there was a variability in the measurement of outcome. So this shows an in-depth analysis of association between parental smoking and childhood myopia. This indicates a potential link between the two, but the evidence still remains mixed, and future studies in terms of longitudinal design and standardized diagnostic criteria are need of the hour, and people should be educated about the risk of second-hand smoking in causing ocular health issues in children.